Good afternoon. My name is Bruce Jarrell. I'm the Senior Vice President at UMB, and it's my pleasure to be here and to introduce this session with a keynote lecture plus a discussion to follow. The title of this address is Future of Tobacco Control, and it will be followed by the discussion. As a way of introduction of this meeting, you are all here at a joint UMB-UM College Park activity sponsored by the School of Public Health here and the Department of Epidemiology at the School of Medicine in Baltimore and the other individuals at the campus interested in epidemiology and public health. About 5 years ago, we realized that both UMB and UM College Park had achieved great success in their research and other activities. And in fact, a number of people said, you know, if you add the two campuses together, you get to $1 billion of extramural funding. That's a lot of money. And that's a lot of ranking with the AAU and other groups. So we engaged in a number of discussions spurred on by the Senate President Mike Miller to talk about how to put these two campuses together in a logical way. And the result of that long discussion was an entity called Empowering the State, which I had the pleasure of leading from the UMB point of view, and Marianne Rankin, the provost here, leads from the College Park point of view. We were able to put together a number of very successful collaborations in the area of tech transfer and intellectual property, in the area of high-end computing and genomics, in the area of engineering and medicine, and here is a fourth area where we're very pleased with many of the activities that have occurred collaboratively. That is to develop a collaborative School of Public Health with the School of Public Health here, with the department up in Baltimore, and a joint MPH degree. But you can see that it's much more than just an educational initiative. It is also an initiative to improve research between the two campuses, and all of you saw the posters. So I think a number of us are very pleased with the progress that's been made. With that introduction, let me briefly introduce the panelists and the moderator of the the panel, and then Dr. Carmona for the keynote address. So the panel will be moderated by Professor Ira Chinoy, who's Associate Dean for the University of Maryland College Park Philip Merrill College of Journalism. He's had a very long and distinguished career in journalism at a young age, and has received 2 Pulitzer Prizes, which I think is a quite remarkable achievement, one in investigative reporting and one in public service. And in his comments, I hope he'll mention those to you briefly. The 3 panelists are Dr. David Ashley, who is Director of the Office of Science at the FDA Center for Tobacco Products, has a PhD in physical chemistry, and will tell you about his interest in tobacco and the emissions from tobacco and how that causes disease, and obviously from a regulatory point of view, how we can lessen that burden of disease. The second panelist is Dr. Pamela Clark, who is a faculty member here at the School of Public Health studying risk behaviors in youth. She is a very well-funded investigator with multiple NIH funding and is the principal investigator of a very special P30 center here centered at College Park in Tobacco Center for Regulatory Science, and I'm very pleased to say that UMB investigators are an important part of that project. And then the third panelist is Professor Kathleen Hoke. Professor Hoke is in the School of Law in the University of Maryland at Baltimore. She is an expert in public health law, leads the public health law clinic that our students study public health issues and learn how to mitigate them. She's an advocate for, obviously, public policy improving the health of our people. So with that, those are the panelists, and that is the moderator. So now I'd like to introduce Dr. Carmona, who is our keynote speaker. Dr. Carmona was the 17th Surgeon General of the Public Health Service, became such in 2002. Actually, I've known Rich for many years. when I was at the University of Arizona, and Rich was a very active trauma surgeon. I think most of us thought of him as Mr. Trauma when it came to Southern Arizona. That'll probably embarrass you, right, Rich? But was very involved in the community in terms of public health from a trauma point of view, all the way from paramedics to acute care to even extracting individuals who had undergone trauma in remote areas and needed to receive care. I learned a lot about Dr. Carmona during that time, including that he was a combat decorated Vietnam veteran on the Special Forces, which means don't mess with him. I also learned that he followed an unusual path to his career, which many people do, but this one was particularly unusual, and that he dropped out of high school to go into the military, got his GED while in the military, went to a community college, then went to a premier institution for his MD, for his training in surgery at UCSF. So a most unusual pathway, and if this room were full of students, that would be an important pathway to point out to them. He became Surgeon General at a time of terrorism in the United States. That would be 2002, and I think it's fair to say the right man for the right time, for the right job. So in his keynote address, he will bring a Surgeon General's perspective on tobacco products and insights as to how we should be looking at the future of the regulation of tobacco products, e-cigarettes, the new thing, as well as our public safety and health in this country. So please welcome Dr. Richard Carmona. Richard, a pleasure.
Thank you, and good afternoon, everybody, to Dean Clark and all of the dignitaries here, and many of my old friends who I haven't seen before, and a special welcome to the United States Public Health Service Commission Corps officers, my Corps of health warriors who are often anonymous, but do extraordinary work around the world in everything they do. And Bruce, thank you for the nice introduction, but when I get those introductions, I often feel a lot like Ricky used to say to Lucy, that you got a lot of splaining to do. It doesn't engender a lot of confidence in your peers when they find out the Surgeon General was a high school dropout. And yet some people probably think, well, it's just another federal official. What's the big deal? Well, I am very proud, very privileged to be here among you, and part of an exceptional group of health warriors, the Surgeons General of the United States. The last 4 or 5 who have contributed significantly to tobacco control through the reports that they released. And I'm very proud to have been a part of that, but I'm also saddened that after all of these years, we're still fighting these battles. And it takes Surgeon Generals and other leaders to be able to step up and lead this battle over and over again. The task before me today is huge and it's complex, and I look at my position today really as being an opening act for the panel that's going to come after me. So I want to frame these issues. Some of them are very controversial, some of them are pretty straightforward. Now, as many of you know, the Surgeon General of the United States, the job description is a simple one: to protect, promote, and advance the health, safety, and security of the United States. Very simple on paper. Now, as soon as you try and execute on that value proposition in a very, shall we say, diverse, if not dysfunctional, political environment, it becomes extraordinarily difficult to be able to do that job. And yet you come to see, as Dr. Satcher pointed out this morning, that the real power and authority, if there is any in the Surgeon General, is in the credibility of the Surgeon General. Because all of us recognize as we step into the position of Surgeon General that we are not the doctor of the Republican or the Democratic Party or independents. We have a much more important job. We have the biggest practice in the world. We're the doctor of the greatest nation of the world, and we serve 320 million or so people right now. And because of that, that's what gets Surgeon Generals in trouble, because you refuse to get pulled left or right. You stay focused on the mission, and the mission is attacked based on the best science. Everybody else gets elected to do the politics. Surgeon General has to rise above the fray. And so what's really remarkable about it, and for those of you who are students of history and you look at the battles that Surgeon Generals fight, some of them very public, most of them very private that you don't know about, you'll see there's a common theme, that each of us recognize that we have the privilege to serve for a finite amount of time. We have the privilege to be the doctor of the nation. We have an extraordinary privilege and a burden to address the issues that are challenging all of our citizens as well as the world, because the position has really morphed into a global position today, largely because the threats and challenges that we face as a nation don't respect our geopolitical borders. Those borders become impediments to good public health often, and we haven't quite yet figured out how to deal with those borders as we read about every day in the media. And although there's no perfect solution, what we do know today that we're not dealing with the border issues very well. And these are borders that we need for economy, but I think we need them for commerce as well. And we need them for health, because emerging infections generally don't start here in the United States. Terrorism generally doesn't start here in the United States. Think about SARS, avian flu, anything else that you've read about in the past few years, and of course you're all health professionals, you know that, but very rarely does it start here. So the fact is we are interconnected, directly or indirectly, with 7 billion other people that are cohabitating this shrinking earth, and we're all struggling to survive and competing for the same resources. And when we look at tobacco, you know, tobacco is one of those threats, not only to us. It's a major global problem. So today, I have this opportunity. Now, it reminds me of being Surgeon General again, because Surgeon Generals often are premier educators. You get before groups like this, and a lot of times it's colleagues, a lot of times it could be high school kids, and you're trying to motivate, you're trying to come with passion with an issue and explain it. Use a lot of health literacy and cultural competence to be able to deliver complex messages to end users in order really to do one thing only: translate complicated stuff to that end user so that they can acquire it, use it, and effect sustainable behavioral change that results in improved health, wellness, whatever your metric happens to be. It's that translation that we often stumble on. But you know, as Surgeon General, it was a very frustrating experience. And there were times that I would joke with my staff. I said, you know, I feel like a cemetery caretaker. And they go, what do you mean? What do you mean, boss? And I said, well, I feel like a cemetery caretaker because sometimes I wonder. I said, I know there's a lot of, like a cemetery caretaker, there's a lot of people under me, but nobody's listening, you know? And I said, you know, we really have a lot of work to do. This issue on the future of tobacco control is a huge one, and it's complicated. And I have a little less than a half an hour to cover the waterfront, so to speak, on this very complicated issue. But what I hope to do for you today is at least outline some of the history as well as some of the issues going forward, so that it will provide fruits for discussion for our expert panel that will be following. It is indeed odd that a product that pollutes our environment and body and results in nearly 500,000 deaths and millions more with chronic diseases that rob the quality of life and add catastrophic disease and economic burden to society is not only tolerated by our government, but in fact is subsidized with your tax dollars. The fact that a global industry of anti-tobacco activists and comprehensive tobacco control strategies and organizations have emerged over a few decades should concern us all. For the extraordinary disease and economic burden they address on our behalf is 100% preventable. The need for a discussion of the future of tobacco control is driven by several issues. The right of the individual to make a poor decision to smoke versus the cost and burden to society. The sometimes criminal and always negligent acts of the tobacco industry and its lobbyists in producing, marketing, and advertising a lethal product for economic gain. Profits before people. Elected leadership ostensibly representing us, but repeatedly failing to act on our behalf on the best science to end the scourge of tobacco-related death and disability. History is the prologue to our future, so it is worthwhile to briefly review the rich and long history of tobacco control. Although we tend to think of tobacco control as a contemporary issue? It is not. In 1590, Pope Urban VII threatened to excommunicate anyone smoking, chewing, or sniffing. In 1604, in London, the new habit of smoking met royal opposition when King James wrote a counterblast to tobacco. He described smoking as a custom loathsome to the eye, hateful to the nose, harmful to the brain, and dangerous to the lungs. In effect, he summarized all the future Surgeon General reports 410 years ago. The earliest citywide bans on smoking in the early 1600s were in Bavaria, Austria. In 1723, smoking was forbidden in Berlin, Germany, and other German cities. But restrictions were rescinded later in the Revolution of 1848. In the late 1700s, Francis Bacon commented on the strange addictive nature of nicotine. In the 1930s, German scientists conducting research concluded that smoking causes lung cancer. So the German government did all it could to prevent smoking. However, once World War II broke out, German research was silenced due to the allegation that it was connected to Nazism. Almost 35 years later, after German scientists made the causal connection with tobacco and lung cancer, Surgeon General Luther Terry and his team published the first and historic Surgeon General report on smoking and health. Historic because the U.S. government finally gave in to science and begrudgingly backed the report, as special interest groups did all they could to block the release. This is a theme that has continued since that first Surgeon General's report. Dr. Satcher this morning spoke a little bit about the release of the first report and what happened behind the scenes. But there are volumes of information that you didn't hear about, of the manipulation and the attempts to silence and not release that report because of the unusual reach of special interest. But for whatever the reasons, the moon and the sun and the stars were all aligned, and Surgeon General Terry was able to release that report. But they put him at a location that they didn't think would get much press. They delayed it. They did a number of things, and yet it resonated with the public right away, and it was a seminal event in our history of public health because of that. 4 decades later, I experienced the virus of politicization as well, as I tried to move forward with some of these reports. And I think it's worthwhile discussing it because the challenge still continues today. The Surgeon General recognizes that they're the doctor of the people and not a political party, and they need to be free to speak. They should have separate funding. They should not only be asked to speak, they should be mandated, in my opinion, to every year present to Congress a state of the nation's health, just like we do the president, the state of health, the state of the nation. We should also be talking about global health since we're always interconnected. Yet, those ideas have been introduced by me and others, and they fall by the wayside. As we rolled out our secondhand smoke report, which took over 4 years to get out, and a lot of the reasons it took that long was the repeated vetting in the political process, where we'd get it back and sentences were stricken that were clear, hard facts of science. And I'd get reports back with a note saying, can't you soften this a little bit? Can't you change this? Can't you do that? I said, no, that's what the science showed. Yeah, but it's offensive, to this group or that group. I said, I'm sorry. Doctors sometimes deliver bad news, okay? And this is bad news, but this kills. And we have repeated delays. And then my team had set up a number of press conferences as well as visits to the morning shows in New York, ABC, CBS, and NBC, to discuss the report and how important it was to the American public. I got a call one day and said, those TV shows have been canceled. You're just too busy. We can't send you to New York from Washington. And then we delayed the release of the report for reasons that were never told to me. And finally, we kept pushing. Now, mind you, this is 4 years of CDC, NIH, public health people doing extraordinary work, reaching out to the world's scientists, getting the best science the world has ever seen on secondhand smoke. Reports came back to me, and I refused, as my team did. We're not going to change this whatsoever. And so we finally were told, all right, you can release the report, but it wasn't going to be at the press club. It wasn't going to be any place. They said, well, you can do it on Pebble Beach, which is really, Pebble Beach is where the White House does their stuff. I said, well, this is a public health report. We probably don't want it associated with politics. So we got buried in the small auditorium in HHS on a Friday. I think it was a Friday morning. I don't remember the exact date. But they picked the day that was worth for press, and we did it. But you know what was interesting? We sent out the announcements, and they didn't think that there'd be traction. The room was packed. Every reporter was there. And I was given a speech to read. I said, I can't read that because it was political in nature. It wasn't science in nature. Surgeon General doesn't speak politics. Surgeon General speaks science. And I was asked to give credit to political parties and political people. And I said, we're not going to do that. And so I recognized, though, at this point in my tenure as Surgeon General, that in competing with the wars and body counts and all the things that make the headlines, that really what was necessary was to be able to take that science and frame it in a cool soundbite, quite frankly, to be able to get resonance. So rather than the preamble that was there, my opening remarks went something along the lines of, good morning, ladies and gentlemen, welcome to this important day. I'm here to tell you that the discussion is over. Secondhand smoke kills. That was a soundbite. But in order to compete with all of the non-public health stuff, you have to figure out how to package that science and get it so it resonates. And we got it out there, and the rest is history. It really was a monumental report that began our nation on a path of smoke-free areas, that about 26 states right away. And just I spoke to people from all over the world who thanked me. And by me, I say I was the agent for this great team from CDC, NIH, HRSA, everybody who contributed, science from around the world. I just got to be their spokesperson as the Surgeon General. But I had ministers from countries all over the world calling, say, thank you. We finally have evidence to be able to do that. So for those of you who have traveled in the EU or the Middle East in the past and you couldn't find a smoke-free restaurant or a hotel, you have smoke-free areas now because of a U.S. Surgeon General's report that went viral and went global. That's how important these things are. And no matter how they try and marginalize the Surgeon General or cut the budget, as I used to joke with some of my elected officials on both sides of the aisle, I would say to them, we both have very public jobs. We have a lot in common, but I have something that you're going to try to gather for the rest of your career in politics. And they said, what was that? I said, credibility. Hey, Surgeon General's never been indicted for any crime. Never had, boyfriends or girlfriends or, malfeasance or anything else. And that's the power of the Surgeon General, because the public has come to recognize that this is a position that has a credible individual who will always tell them the truth so that they can make decisions that are best for them. And smoking was a seminal part of that for me as well as the other Surgeon Generals. When I went to Congress to speak about tobacco, which happened on more than one occasion, on one particular occasion I stayed for a couple of hours and I was pummeled by various Congress people asking me why would I not advocate for smokeless tobacco or alternatives to be able to hit the market. And I said, well, I really can't. There's not enough science. But Congressman, if you'd like to give us funding, we're happy to do some studies and determine. But that never came. But what was interesting, one of the most aggressive questioners of me, who was a congressman, was a family physician. What state do you think he was from? Kentucky. Okay. So, the point I'm trying to make to you, you see the insidious nature and reach of special interest groups that really, through history, control and move all of this, and sometimes to the detriment of us. And for the students in the audience, to be an effective public health practitioner, you have to understand the politics of your community, your state, and the nation to understand how to navigate and move agendas forward. Without that, you cannot be a completely effective Surgeon General. So, as we move forward to modern tobacco control, we went from local to global over 3 decades. The multi-pronged, comprehensive tobacco control slowly evolved in the U.S. and abroad, driven by academic studies and a few brave politicians not afraid to buck the special interest groups, like Mayor Mike Bloomberg in New York City, who took New York City on the path of going smoke-free, coincident with our Surgeon General's report in 2006 for secondhand smoke. And Tom Frieden and I, Tom was the New York City Health Commissioner before he was at CDC, and we used to do a lot of scheming behind the scenes so we could share information so he could get it to his mayor. But the difference was he had a mayor, and I said this to him a number of times when I'd go to New York and we'd have lunch, and I'd say, Tom, you have an enviable position as a public health professional. He said, why? I said, you have a politician that you report to who is fearless and is beholden to no one. That's it. So when the mayor was convinced he had the data, he said, we're going smoke-free. And every special interest group came out and screamed and yelled at him. He didn't care because he'd already done the work. And in fact, the initial studies showed that actually tax revenue as a surrogate for commerce increased in places that went smoke-free. And he actually was doing a public service as well as an economic service. Okay? But the special interest groups didn't want that to happen. But that's a unique situation when you have senior public health officials who will be given top cover, if you will, by the senior elected leaders to be able to do the right thing and not be influenced either way by many of these special interests. Individual cities' efforts eventually came together globally under the World Health Organization in the form of the Framework Convention on Tobacco Control, the so-called FCTC, in May of 2003, signed by 168 countries, including the United States, but never ratified by the United States. That's interesting because, in effect, we are not obligated to it since it wasn't ratified by the Senate. Now, what's also interesting is then young senator named Barack Obama wrote to President Bush with other senators urging him to send this document to the Senate for ratification because of the importance it would have on the health of our people. It was never done, but neither has it been done by the Obama administration in the 5 years they've been in office. What a coincidence. Or is this a demonstration of bipartisan dysfunctional cooperation with the tobacco industry? The FCTC is built around the acronym of EMPOWER. M, to monitor tobacco use. P, protect public from smoke. O, offer to help quit. W, warn about danger of tobacco. E, enforce the bans. And R, raise taxes. So with the past in mind and as a prologue to our future, the problem remains the same as articulated by leaders over 4 centuries ago that I've recounted to you. Except that the politics and political infrastructure and special interest groups make it much tougher today to move these agendas forward. Here are some important future considerations for tobacco control, and I've kind of put them in categories. Individual, the issue of prevention, cessation, and treatment. Obviously needs to be more aggressive. We need greater utilization. That's been reported in the literature. Current behavioral treatment, pharmacologic prevention studies seem to have all plateaued. We're at about a 1 in 5 smoking rate. If you're in the military, it's about 1 in 3. And that's plateaued. So clearly we're not applying them well enough, or they're just not effective as we thought they were going to be. Whether it's the patches, whether it's gums, whether it's sprays, behavioral therapy, combinations of those things, we've plateaued, as many of you know, for the last, and we've had some, some modest success, but when you look in aggregate, we still have a big problem within the country. And of course, the quit rate is sometimes eclipsed by new smokers, and the quit rate is pretty low. When we look at population health, going from individual to population, we need to do everything we can to continue to stigmatize smoking, that it is not socially acceptable. I know when I'm in public areas especially, and you see somebody lighting up, even on an outdoor patio like in California, they'll get the meanest glares you ever saw, okay? And people know we can't do this. It's socially unacceptable. We have to do everything we can with cultural competence and health literacy to educate. We are a heterogeneous society. One size doesn't fit all. The very diversity that makes us such a strong nation also divides us and makes it more difficult to deliver effective public health messages because we have so many languages and cultures and belief systems. Health literacy and cultural competence is the language of all public health professionals, and it's essential if you're going to be a public health professional. Financial disincentives as far as population, insurance rates, stratification, higher insurance rates for smokers. Maybe they've helped a little bit, but not that much. We look at workplace issues. Plenty of you are probably aware some places refuse now to hire people that smoke. Cleveland Clinic was probably the first that went out as a large health organization to say, you can't work here anymore. Those have been challenged sometimes, but so far they have done okay and prevailed. As we move into the policy area, we look at things like risk of vulnerable populations. We see smoking at a higher rate in so-called minority populations, poor people, lesser education. And then we get into the issue of menthol cigarettes, where we find there's a higher use of those in those vulnerable populations, which makes it even more difficult. Yet they're kind of the sexy selling, tastes good, and the sense that it's better for you. It's not. They still kill you. They just kill you with a better taste. That's all. And so the issue of vulnerable populations and addressing social determinants of health, as my friend and colleague David Satcher pointed out this morning, are extremely important because they're directly related to this issue. In Arizona, where we have a lot of Native American tribes, we see the smoking rates very high. We see the cancer rates bad. We see obesity. We see type 2 diabetes. But yet it's a public health officer that's retired, Dr. Leland Fairbanks, who's taken up the charge to try and make all the casinos smoke-free. And he's done an extraordinary job, and he's been retired for decades. And he's still a public health officer. And he's out there making deals with the gaming people so that he can start moving them towards smoke-free areas. I've often said that it's challenging that, why we don't even have just an outright ban on tobacco. And I know that's kind of politically incorrect to say in some circles, but the data is so compelling that if we had 500,000 people a year dying in plane crashes, all the planes would be grounded. I mean, it just doesn't make any sense. But yet, because of the interests of others and profits before people, the people continue to suffer because of this. As a matter of policy, we should be striving, if we can't get rid of tobacco, to reduce the nicotine content as much as we can as we move forward. We need to push hard back at Congress to get bigger warnings like the Canadians have, like the Europeans have, that make it clear that this is bad stuff and you're killing yourself. Most of this stuff gets watered down. Why? Because special interest groups water it down. The increasing taxes has been heralded as decreasing usage, but it also has a downside, as many of you know who study this. Because once the communities get addicted to the revenue stream from those taxes, it's very hard to get any of those city councils, boards of supervisors, state leaders to say, okay, we're going to do away with tobacco, because where will their revenue stream come from? So there's an unintended consequence of a good input, which is to raise the taxes. And then, of course, we certainly need to work to expand smoke-free areas, as we have been doing, and increase funding for research and best practices as it relates to prevention, cessation, and treatment. Now, when I was Surgeon General, one of the things that I used to do, and Patricio, my aide, who's back there, he used to kind of get embarrassed. We'd be driving, I'd see people smoking in the street, and I'd stop the car. I'd tell the driver, stop. And I'd be in uniform, and I'd go out to somebody, I'd see somebody smoking. I'd say, hey, you're smoking. And they'd look at me, say, who are you? I said, I'm the Surgeon General. And the guy, literally this happened one day, he said, I'm the Surgeon. I said, I'm the Surgeon General. He goes, no shit, really? Yeah. And I said, yeah. And I used to do this all the time, and I'd say, and I'd give him the pitch about why smoking, don't smoke is bad. And you know what's interesting? Like the data, probably 3/4 of the people said, I really want to quit, but I can't. I've tried. I failed 3 or 4 times. But then I'd have people that say to me, after another drag, I'm an American and I can do what I want, and you can't tell me what to do. Therein lies the problem. The individual rights versus the collective rights of society, extraordinarily important issues as it relates to this problem. But I used to, even with that, every time I'd stop, I'd take the cigarette pack, and I'd sign it and say, you see here where it says on the bottom of your Marlboro box, it says Surgeon General warning? I said, I stay up all night signing those things so you won't smoke, okay? And I'd sign it, and I'd say, Rich Carmona, Surgeon General, don't smoke, it kills you. And I'd give it back to him and say, just try. And I'd give him a quit number. I'd give him an 800 number, and I'd try and get him into the system to do it. So we had a little bit of fun with it, but it's a terrible problem. We need new disruptive approaches, behavioral modification, pharmacologic, technology. We have a lot better understanding of the addiction properties of nicotine and tobacco now. Look at the work that Nora Volkov's done up at NIDA, with functional MRI and such. So there's a lot that we can apply in science to try and help people break this habit and or prevent. We need, directed merit-based funding for these best practices. Now, there's two areas that I'm going to close in that are real important one you hear about a lot and one you don't. The first one is the e-cigarettes. Our public health professionals are divided on this. Some feel the abstinence-only crowd, stop, nobody should be smoking, get them off it, have them quit. I understand. But as a public health professional, I've seen where abstinence-only doesn't work in a whole lot of areas. And so we need something in between. So my sense is I think that there is still more research needed, but that there is a potential for e-cigs to be a contributor in harm reduction. But I respect my colleagues who think I don't want to go down that route because nicotine is addictive and I don't want them addicted to anything. But on my side, I look at it and say, well, I'd rather have 50,000, 50 million, 50,000 people addicted to a nicotine delivery device with no carcinogens than addicted to the carcinogens. And so I'm here to state it is definitely a controversial issue within public health. Some of my closest friends who have been strong advocates against tobacco, like I have, feel differently, but the science has to advance to give us, direction. But I think there is merit at least to considering this now, or I wouldn't have taken that stand to say, let's look at this. Let's look at this because I think there's great potential here. The other area that we need to look at in the future is the whole issue of the epigenetic effects of tobacco on the genome. Genomics are extraordinarily important. The methylation that's taken, the science that's come out already showing what methylation does. And what's interesting is tobacco actually puts a footprint on your genome. And geneticists now can look at that genome and see how alterations have taken place over time. And you can look at things like methylation that will turn on or off genes that are beneficial or can hurt you. So we're starting to really understand the molecular basis of the cancers and diseases that are caused by the epigenetic effect of tobacco on the genes. Very important area as we move forward because as we unlock some of those secrets, it may make it a lot easier for us to address some of these amazing challenges. Our data is compelling for the health case and the business case that relates to tobacco. We know that $150, $200 billion a year, direct and indirect costs, $2.8 trillion budget for what we call health care. It's actually sick care, not health care. As many of you know, that's increasing. And the thing is that it's all preventable. When you start looking at the economic burden as a nation we have from all that's preventable, and you look at tobacco, and we're fighting over budget, I'm appalled that I don't hear my elected officials talking about let's address the preventable side, because that's where all the money's going, okay? 75 cents of every dollar we spend in that healthcare budget is directed at chronic diseases, most of which are preventable. And no matter whose party is in power or whose plan you put in place, if you don't address that, what we can predict is the cost will continue to rise. And the bank is breaking now. So we have no choice but to do the right thing. And it more or less reminds me of paraphrasing what Winston Churchill had said, that I love Americans. They always do the right thing, eventually. And we're at eventually now. We have no choice. Because even if you have ignored the science for decades, you can't ignore the economic burden that's upon us, that's crushing us, and the legacy we leave our children will be unsustainable unless we address these issues very quickly. So thank you so much for being here for this important issue. I am thrilled to be part of this and be with you as one of the Surgeon Generals, and I look forward to our experts' discussion on these issues. Thanks very much.
Thank you, Dr. Carmona, for setting the stage for what I hope will be a terrific discussion going forward. My name is Ira Chinoy. I'm the Associate Dean in the Philip Merrill College of Journalism here at the University of Maryland. And I am not an expert on tobacco control, but we are joined by three people who are experts and have long careers in that area. And so what I'm going to do in a minute is invite each of them to talk to us for 3 or 4 minutes about sort of how they are engaged in the world of tobacco control, and maybe what they see is 1 or 2 maybe very specific kinds of challenges that might lead to research and action. We're here at a major Research One university, and so what are some of the things that need to be researched? When they're done, I'm going to come back with 1 or 2 follow-ups, and then we'll open it up to you all. So I think we'll start with Admiral Ashley at the end, and take it away.
I'm going to go to the podium. If
that's fine, yeah.
Well, first off, thank everybody for the invitation to be here. It's actually kind of fun to be on the University of Maryland campus and to see everyone. It's also really exciting to me to see the number of uniforms out there, and that's really great. I'm David Ashley. I'm Director of the Office of Science in the Center for Tobacco Products at FDA. I have been in that position for almost 4 years. The center itself has been around for 5 years, so I got in pretty early on the ground floor. Before that, I spent 27 years at CDC. 15 of those years were spent in tobacco, and Pam and I have worked together for probably about 20 years on and off. So let me tell you a little bit about what we do in the Center for Tobacco Products, and I am going to keep this very, very short. On June 22nd, 2009, the Family Smoking Prevention and Tobacco Control Act was signed into law, and that gave FDA authority over cigarettes, cigarette tobacco, smokeless tobacco, and roll-your-own tobacco. It allows us the possibility of asserting jurisdiction over other tobacco products through rulemaking, including things like cigars, pipes, e-cigarettes, hookah, and other products. We have already expressed our intention to deem our authority over those tobacco products. We've been working on that for a lot of years. October of 2013, our rule went to the Office of Management and Budget, and we're still hoping to hear from them soon on exactly how we can move forward with that. We use our regulatory authority in about 8 different ways. There are 8 different things we do in the authority that's given to us by Congress. First is understanding the regulated product. Now, the years I spent at CDC, most of that time was spent trying to understand the product, but I'm now in a position where I get a much better view of that because the industry has to report to us things like ingredients, constituents. They have to register and list with us, so we get information. We also have access to health documents, the research they've done. And so one of the things we do is we are able to understand the product much better than we have in the past. A second thing is restricting product changes. And so every product that goes on the market, every new product that goes on the market goes through my office. We look at those products to determine whether they meet the regulatory requirements for marketing. And right now, the primary things are something called a new tobacco product application, which means we have to determine whether those products are appropriate, whether marketing of those products are appropriate for the protection of public health, or there's another pathway that Congress put in the bill called substantial equivalence, which means if the companies can show that the product that they intend to market is really substantially equivalent to a product that was on the market on February 15th, 2007, then we can allow that to be marketed also. And so those are the 2 pathways they have to market, and so we spend a lot of time looking very carefully at those products and trying to determine what their impact is going to be on public health and whether we should meet the requirements in the law for allowing their marketing. We prohibit modified risk claims, and so immediately after the law was signed, you saw low, light, and mild no longer on packaging. We are also, if the companies make any kind of a claim that we can show that they're trying to communicate that this product is safer, they have to prove to us before they do that. And so we go through a lot of work with that in trying to make sure that they are not making false claims about their product. We restrict marketing and distribution to protect public health, and there was a rule that was introduced back in the mid-90s by FDA that was kicked out. We reintroduced that early on in the process of of exerting our authority. And so we now have a national minimum. You guys may not have realized before, a few years ago, we did not have a national minimum age for smoking, and now we have a national minimum age for smoking. Companies are no longer allowed to distribute free samples or to sponsor particular events as a way of promoting the use of the product. We decrease the harms of tobacco products through product standards. And this is the thing that I am most excited about the authorities given us under the Act. We can, if we've got the science, if we've got the scientific basis for making these decisions, we can require the companies to meet particular product standards. And they have to make their products conform to those standards. Now, there's certainly a scientific prerequisite that we have to put into place to show that those actions are appropriate for the protection of public health and they will have an impact on protecting health. But those product standards really provide the potential for an incredible effect on the tobacco market. We ensure industry compliance. We have folks that go out and do manufacturer inspections, that go into the factories and look and see what they're doing. We also pay groups within each of the states to do retailer inspections. So they go in and try to do underage buys, and we send out warning letters that escalate up into civil money penalties for those who do not follow the law. We educate the public through warnings on packs and in advertising. But we must publish the information that we put out there in a way that's not misleading and it is understandable. How many of you guys have seen the new real cost campaigns that has come on TV? Has anybody seen that? I've seen it. I've seen one. That's probably actually good because it's not designed to appeal to adults. It's actually designed to appeal to at-risk kids. And so it's actually been where you will see it is things that 12 to 17-year-olds watch, and it's actually pretty good. I was actually very impressed with, I wasn't responsible for it, but others in the office were, and I was actually very impressed with what we've got. So look for it. You'll start to see ads, you'll start to see bus advertisements and things like that. We also expand the science base for regulatory action and evaluation. We're currently funding right about $200 million a year in new tobacco research, which is, to me, a very exciting thing, having done tobacco research for a long time, being able to put money out there so that we can get research done that will inform our regulatory actions. So those are the things we do. There are some things we can't do within our own authority. There are other parts of the government that may, but within our own authority. We can't implement state or federal taxes. That's not our responsibility. That's other people's responsibility. We don't regulate therapeutic products. So tobacco products that are used for therapeutic purposes, we do not regulate within the Center for Tobacco Products. That's regulated in the Center for Drug Evaluation and Research, another part of FDA. We don't set clean indoor air policies. That's done by the states. We don't regulate tobacco growers. That was a carve-out that was included in the statute. We cannot require the reduction of nicotine to zero. It doesn't say we can't require the reduction of nicotine to something real close to zero. We can't ban all cigarettes. We can't ban all smokeless tobacco products or little cigars, other cigars, pipe tobacco, or roll-your-own tobacco products. So we can't put out a ban on products. So those are the things we can't do, the things we can do. All of our regulatory decisions are made upon the best available science. We've got a lot of work that's going on in that area. It's actually very exciting to me. We're funding a T-Course here at the University of Maryland. We're funding actually 14 T-Course around the country. Those are tobacco centers of regulatory science, and very excited about the work that's being done there. The work in tobacco science is continuing to expand. We're expanding our work in our own office. We are hiring very regularly. Everybody from engineers to social scientists, the full spectrum of scientific subject matter expertise. And so that is very exciting to me. When I joined the center 4 years ago, we had 15 people in the Office of Science. We're now up to 180, and we're shooting up past 300. And so we're continuing to hire people in there. No doubt, for me, this has been the most exciting 4 years of my career because of the way that I've been able to see law and science come together and make decisions. So I look forward to the further discussion and questions from the audience.
okay if I stay seated?
That's fine.
Okay, Pam and I are staying seated. So thank you for inviting me to talk to you today. What is a lawyer doing in the room would be the question, right? So don't worry, first of all. Oh, you can't hear me? You want me to stand up? Okay. They're telling someone's
Okay.
telling us to stand up. Okay. I can do that. So what is a lawyer doing in the room today with you? First of all, I'm one of the good guys, so that know that. But what I hope to do with just a few minutes of time here is explain to you the role that lawyers can and do play in tobacco regulation. So certainly some of the staff at the Center for Tobacco Products are lawyers. Lots of them in the Office of Policy. In fact, they recently hired one of the people away from me. So congratulations, David. So in context, at the law school, we host the Center for Public Health Policy. Used to be called the Center for Tobacco Regulation, Litigation, and Advocacy, but we've expanded our reach. What do? We provide what we call technical legal assistance to state and local public health officials, their staff members, legislators, community groups who are working to improve public health. For our purposes here, in tobacco control in particular, we've been doing that since 2001. And what does that look like? Well, when a local legislator called in 2006 and said, we want our county to be smoke-free. Smoke-free bars, smoke-free restaurants, smoke-free everything. Do we have the authority to do that? If so, how do we exercise that authority? As the county council, as the county board of health? Who can enforce this? How can we enforce this? What does the state law that existed at that time in regulation preempt us from taking action? So any number of legal questions arose. If we have an exemption for tobacco shops or cigar bars, does that violate equal protection such that our law will be struck down? That was a common challenge that was raised to laws around the country. And so folks reach out to us with those types of legal questions as they're working through the policy field. And so it's important that we understand the evidence base, right, behind the policy so that when we're talking to folks about whether they have a rational basis for their law, is this law going to withstand scrutiny? We as the lawyers need the researchers to be able to talk to us in regular people English. We'll try to talk to you in regular people English, and if you'll try to talk to us in regular people English, it'll work, so that we can translate that research, overlay it with the law into effective policy. So if I can just walk you through one example using the electronic cigarette, or we call them electronic smoking devices, call them what you will, there's no one name. But what has happened in the last couple of months, frankly, or a year for us is an influx of questions about electronic smoking devices from counties, from state government, from individuals, from restaurant owners, from employers who have said, first question, who may sell these? Right now, anyone. There's no license required to sell electronic cigarettes. So we've talked with regulators at the state level about whether and how they might implement a licensing scheme to sell electronic cigarette smoking devices. Would it just be attached to the tobacco retailer license, or should there be something different here? And if different, what would that look like? To whom may they sell? Maryland did pass in 2012, as have many other states, a law prohibiting the sale of electronic smoking devices to minors. So they did that through state legislation. Local jurisdictions may also pass that type of legislation so that they can enforce it at the local level as well. Then taxation. Is it a tobacco product or not a tobacco product? Well, according to at least one federal circuit court, it's a tobacco product for the purposes that are relevant to David here today, because they said the FDA has to regulate electronic smoking devices as tobacco products. But under most state laws, they don't meet the definition of tobacco product, and so the rules about whether they're taxed as tobacco products and where they may be used aren't the same, or frankly are non-existent. The tobacco rules don't automatically apply. But that's the world we're in now, where a lot of local jurisdictions and state jurisdictions are saying, we want to regulate them that way. May we do that? First question is always, do they have a rational basis for doing so? And that's research. And I think, as Dr. Carmona told us, there's research on both ends of this, or there's research all over on this, and we don't know for sure. Is this a time when we exercise the precautionary principle and say, until we know more, Let's leave them out of indoor places. Let's leave them out of the hands of minors. Let's regulate them in ways to make them more safe, as we're learning more about them. And so walking through these questions of who has the authority, who can do what, can a school system say, no use of these devices on school property? By the way, in Maryland, the answer is yes, and many school systems have. That's not the same question that y'all might be answering. Should they? That's a different question. So they're asking us the authority type of questions. The last thing I just wanted to mention is, I think I said, what's the big concern, or what would you like to see happen? I'd like to see policymakers be able to understand the research that you do. I would like to see policymakers care about the research that you do, because it's really hard to get their attention. And so hopefully working with folks like us, like lawyers and advocates, we can take the really great work that's being done at the T-Corps and really across this campus on any issue of public health, frankly. We do anything. But to be able to package that up in a way that our policymakers, whether it's a state legislator in Annapolis, the Prince George's County Council, whether it's getting the governor to issue an executive order or just informal policy being implemented here on campus, we'd like to help be a part of translating that research into sound policy. And a bright future for me is one where policymakers not only understand but care about that and pass laws based on those principles.
Now hear from Dr. Clark.
Thank you so much for inviting me. This is very exciting to me. I study tobacco, and I'm against it, just in case anybody, got a lot of money for studying it, but I'm against it. I studied hookah, and did you know that the hookah buzz that people enjoy when they smoke hookah is actually carbon monoxide poisoning? All the CNS symptoms, carbon monoxide poisoning. If you had somebody smoking a hookah for a long period of time, and you drew their carboxyhemoglobin levels, you would be taking them to the emergency department, thinking they had been in a car in a garage with the engine running and the door closed. I studied variation in pH in cigarettes, and when you add pH to a cigarette, you add base to the cigarette. It's called free basing. And what's the difference between crack cocaine and cocaine? Crack cocaine is highly addictive because it's free based. It gets to the brain very rapidly. We've got the first evidence that we get physiologic reactions from higher pH cigarettes than lower pH cigarettes. We're studying menthol cigarettes. I was asked by the National Cancer Advisory Board a few weeks ago, well, we see this article and the lung cancer rates are not higher with menthol cigarettes than with non-menthol cigarettes, so they must be okay. A cigarette is so lethal, so very lethal, that to find an additional lethality because of adding an additive to it is just not likely going to happen. We're not going to find that out. But what we do need to do is look at a broader definition of public harm. Harm to the public, not just the individual who's smoking it. If you add menthol to a cigarette, it's a lot easier to start smoking. The poison goes down easier. It's harder to stop smoking. You get more returning to smoking after quitting. So menthol is not a good thing from a public health standpoint. Now we're studying e-cigarettes. Knew we were going to hear about e-cigarettes all day today. We're looking at them from three different directions. The center has 3 R01s attached to it, plus the other R01s we already had going with our partners before we got the T-Corps. We're looking at the microbiome. Tobacco is really dirty. And if you think about how it's prepared, somebody in Brazil with no shirt on because it's very hot and very sweaty reaches up and takes the leaf off the top of the tobacco plant, because that's where the highest nicotine levels are, and sticks it under the arm. And then takes another one and sticks it under the arm. And then when it gets enough, drags it across the ground and throws it into the truck with all the others. Then it gets taken off to be cured. And that's a nice, hot, moist, dark environment, perfect for growing bugs. And the stuff is really dirty. There's lots of stuff in it. Then we're also looking at the products, including e-cigarettes, from a consumer acceptability standpoint. And I say consumer acceptability instead of abuse potential, instead of addictiveness, because people who classically study addictiveness have a way of doing things, and they don't accept my way of doing it. My way is they do EEGs on people while they're using the product and see how the brain's reacting to the product. Because if you just ask them if they like it, they always like their own best. They don't like some strange new thing they've never tried before. So we always do acute laboratory studies and say, what's the brain telling us? And then we're looking at toxicity of all these products. We're looking at the smoke chemistry and the distribution of particles through it. And that's for all these products. Now, we've been talking today a lot about e-cigarettes, and somebody always asks me, should we get rid of them? Are they harmful? The studies are all over the place, and the reason the studies are all over the place for two reasons, I think, just my opinion, and you may disagree with me, Dr. Carmona, but first of all, they were using the first generation product, and the first generation product just isn't as effective in delivering nicotine as the later generations are. The later generations, you can actually manipulate the voltage of the battery, and if you increase the voltage of the battery, you get more nicotine, so the person could get more out of each cigarette. The other thing is they were using naive users, and naive users don't know how to use them, and people learn very quickly how to use them, how to pull on it very slowly so the battery gets as hot as possible, and in some cases explodes. That's not a good thing. So I'm really hoping in this discussion we can get some discussion going about these things, because I have true equipoise about it. I think it's maybe unethical to take away a product that could help some people quit. And again, it looks as though the quit rates with e-cigarettes might be just about the same as the patch, right around that range. But it may be, and that was with the first generation products. It might be better with later generations. And everybody needs something different. Everybody finds a different way to quit smoking. And I think everything that we can bring to the table to get a choice from, or try one thing after another, which is what a lot of them do, and then finally quit, that's a good thing for that person and for public health. So, I can't answer that question. I'm really hoping to hear something, especially from the audience, about it. Thank you.
Thank you. I'm going to ask one quick question of the three panelists and Dr. Carmona, if he cares to answer as well. And then, because we're about 10 minutes away from being done, so quick answers, and then I would like to have some answers from, some questions from the audience too. So I was fascinated to read before today and then to hear you all talk about e-cigarettes. And I was really interested to hear about the idea of the plateau, right? There, these that you talked about, Dr. Carmona, that we've gotten so far in reduction of smoking and so forth. So there is this debate, is this transitional or not? My question has to do with behavior and the kind of the image, the e-cigarette companies potentially sort of promoting an image that this is cool to do, and the term I think I read was renormalization, and there was a lot of buzz in a recent Hollywood event about celebrities who were sort of lighting up. And so I'm really wondering about if you could, maybe the four of you just talk about the image issue in addition to the science issue, and is there a danger that, or not, that e-cigarettes will sort of make smoking in general seem glamorous, that young people won't make the distinction, if you have a thought about it?
In general, I think there are a lot of, let me just say, as far as my personal feelings about e-cigarettes, I think e-cigarettes can be an incredible solution to the morbidity and mortality from tobacco products, or they can be an absolute disaster. And we're kind of on the precipice there of determining which way that's going to go. If e-cigarettes will promote cessation, if people who dual use will quit over a period of time, if they will not promote initiation, that's all really, really good. That is something that will have a very positive effect. If e-cigarettes end up bringing more people in that begin using them and they're not satisfied and move on to cigarettes, that's an absolute disaster. If they renormalize everything that people believe about cigarettes, that's a disaster. If they stop people from quitting, that's a disaster. So we're really right there on the precipice to determine that. I think the glamorization is a big issue. I think that's a major issue because the companies clearly want to draw people to their product, and they have the right to try to draw people to the product. But the way they portray it, one of the real questions is, are they trying to get adult smokers to quit, or are they trying to get kids to start? And if you look at how the products are portrayed, ask yourself that question. When you see a commercial or some kind of a promotion for the product, is that commercial appealing to kids, or is that commercial appealing to older smokers who might switch to that product?
And if I could just add, or is it marketed to folks who are smoking and with the desire to continue to smoke and to have a product to use when they're not permitted to smoke? And the reason I mention that is that's what undercuts clean indoor air laws, is if, part of the goal of a clean indoor air law is to get the population smoking rates down, because if people can't smoke in public places, they're less likely to smoke at all. But if they have a product that they can use in those public places now, which that's a lot of the ads that you'll see is, kind of vulgarities toward the Clean Indoor Air Acts, with the e-cigarettes. So that's the other concern. And I will say, a lot of the policymakers who reach out to us for assistance are saying, we know the science isn't there about the secondhand vapor and whether it causes any problems. We don't like the look of it. We went smoke-free for a reason. We like it. We like the image that we portray at our health department, on our county property, at our schools. We don't want this to subvert that.
Yeah, like I said, I'm really of mixed mind about this sort of thing. There's no doubt about the kind of advertising that is smoke where you can't otherwise smoke. You can vape instead where you can't smoke. Oftentimes the images in the ads are in bars. Very glamorous women. Jenny, yeah. She's doing a lot of ads for them. We don't know enough, and I hate to ever say that. I hate to end a talk saying we need more research. Sure, I'd like to do more research, but one of our problems with these things, and a lot of things in tobacco control, is that the companies are so agile. I mean, I got my first grant to study e-cigarettes in 2011, I think it was. And by the time I get the grant written, get it funded, hire the staff, get the startup, get the people recruited in the lab, get the lab going, they've changed 2 more generations. They've changed the product so radically. We're seeing it with smokeless tobacco. And with smokeless tobacco, you can get a can off the shelf and it may be quite a different product by the time you finish your testing of that same product, because you can see there's a little difference, like the tin has rounded edges now instead of straight. So if they're changing the packaging, they may be changing anything about the product itself. I was talking to somebody from BAT, and he said they put out a snus, that's the Swedish word for snuff, and all of the tobacco companies, the cigarette companies now have smokeless wings to them, putting out these products. And he said, we test marketed in South Africa, but it didn't do very well, so we tweaked it for the South African taste. So we can't run fast enough. And one reason we developed our T-course the way we did is try to get more agile. When a new product comes out, get all over it. Understand it as fast as we can get over it. But they're way ahead of us, and they always will be.
Dr. Carmona?
First, Pamela, I do agree with you and my colleagues. I think you've spot on, and David, your summary was, I think, excellent. It can be, e-cigs can be that potential new disruptive technology that could bring great value to harm reduction, but it also could be a challenge. And as was pointed out earlier by Pamela, we have different iterations. First generation, second generation, we have a number of companies. A number of these companies have sold out to tobacco companies, and I won't talk to them. So they call me and ask me before. I said, I won't talk to you. You're a tobacco company. I'm not involved. It's only one company that has stayed out and said they're going to be independent, and they profess to want to make tobacco obsolete. I said, okay, I'll talk to you. But if you want to continue to talk to me, you need to go to the FDA. I don't want them having to chase you. Go to them and ask to be regulated appropriately. And agree that you'll never market to children. Okay, and I had a whole list of stipulations. And if you do that, then I'll continue to talk to you and work with you to try and move the agenda forward. But if you're not going to do that, or you're going to sell out to a tobacco company, I won't even talk to you. So I think they've all made very, very important points. I'm cautiously optimistic based on the fact that it's a nicotine delivery device. It isn't tobacco. It doesn't have the carcinogen and so on. But I'd be the first to say we still need more research.
Yeah, could I ask David a question?
Asking them whether you can ask me a question?
She's asking you a question.
Am I allowed, group, to ask David a question? one of my concerns is that if you take authority, if FDA takes authority over e-cigarettes, we'll never see an independent study of cessation with them, because we can't do INDs. You know,
What is an IND?
Investigational new drug application. And you would need an investigational new drug application if you're going to test something for cessation purposes, for a health purpose, correct?
Uh-huh.
And that means, what are we going to do about that dilemma? Because they need to be regulated, but we need to have the good long-term clinical trial to say, are these effective in quitting?
That's actually a very interesting, very easy question to answer. Thank you for tossing me a softball up there. Because right now, it doesn't matter if the Center for Tobacco Products starts regulating them as tobacco products. If e-cigarettes are being evaluated for a cessation claim, they're already under FDA regulation, and you have to go to CDER, the Center for Drug Evaluation and Research. So that's a done deal already. So it has nothing to do with whether FDA is able to deem authority over tobacco products.
All right, I have like a million questions because I'm a journalist, but I'm going to open it up to you all. And if you would just stand up, say who you are, and shout really loudly. Adele. Or you're welcome to come up and ask your question here, either way.
So I guess I can speak. Can you all hear me?
Yeah.
Yeah, so my name is Adel Shir Mohammadi. I'm Associate Dean for Research and Associate Director of Maryland-Baltimore Experimental Station. So we have lots of research and extension, sort of research and education centers across the state. State of Maryland, as you all know, about 10 years ago, they had a buyout program for tobacco. That means they paid the farmers not to plant tobacco. There are only 2 years ago that I knew, there were only 7 small farmers in southern Maryland that they plant tobacco. The rest have changed into some alternate crop. And in fact, one of our research and education centers in Upper Marlboro, they converted into alternate crops so they can show how to plant alternate crop instead to be economically viable and so on, and they educated. So my point is this, that Dr. Carmona and of course panel members, I know FDA is not politically involved, but Sergeant General, I mean, these kinds of conversions require some incentives, some funding, some, how should I say, to reduce the production of the tobacco. By the way, we have done some small amounts of research that you can produce proteins, some sort of protein. There are different types of vitamins in tobacco, and you don't need to go through the planting and all that laborious type process. You can just, as a vegetable, you grow it, you can use it for medical purposes. But yeah, so those are issues that I think if we want to change the whole national type scenario, we could start also from those aspects.
Good.
I think the point you make is an excellent one. When I was in office, one of the things we did was to offer that type of alternative. When we looked at the numbers, we looked at the disease and economic burden, and we looked across the board at everybody's planting tobacco. We said, okay, why don't we do an initiative here where we will start to substitute crops? Because the first thing I was faced with was, well, you're insensitive. You're going to put people out of business, and families who have been farming for generations will have no jobs. I said, no. I'm willing to support funding alternative crops. Grow healthy stuff and deal with health disparities and so on, get good food to people. And then we went to committees of jurisdiction. Nobody was willing to entertain it. That was it. I mean, the thought leaders, not just me, but around me at the time, all thought this would be a great idea and a win-win. So that it wouldn't affect the economy, so it would help health, but we couldn't get any traction on the Hill.
Great. I have a question for, hang on a second. We're at 3:30, can we go another 10 minutes or so? Or is that going to mess us up?
I think that we may need to finish early on closer to
Time.
time.
All right. We'll take one more question here, a brief question, and then we'll wrap it up.
I'm Renee Fox. I'm a pediatrician and faculty member at the School of Medicine and executive director of the Institute for a Healthiest Maryland. And I really want to thank the panelists for their contribution. But I'm a pediatrician, and I have to tell you, driving down here, there was a truck that wasn't about tobacco cessation of e-cigarettes. It was flavored tobacco. It was a flavored thing. I think that, I'm sorry, but I think you're fooling yourself if you think the tobacco companies
sorry, and I meant to ask everybody, if you know somebody who's using e-cigarettes, especially second or third generation, that they can refill with the e-juice. The e-juice does not have child-proof caps on it. It's enough nicotine to kill a 2-year-old, and it's enough nicotine to kill the dog that grabs hold of it and bites into the plastic. So please ask them to keep it safe, until somebody can do something about how it's packaged.
And that's precisely the type of policy making that we're talking about makes sense at this phase, to regulate that the cartridges have to come sealed, that they're not available in flavors. Let's not get that into the market and then have to try to pull it back out. Let it taste like tobacco, because that doesn't taste very good. And because these liquids are available in strawberry and vanilla and what have you. And that's what policymakers can and should be looking at now, while we're waiting for the kind of bigger action and the bigger science to let us know if it can be used effectively for cessation. I think that's a great point, Renee. Of course, I work with Renee, so.
I don't really have any more to add. I think you actually captured it pretty well with the way you expressed your question.
Anything else? Okay, so we've come to the end. The thing I will be watching over the next few years is whether as tobacco moved from a debate, he said, she said, decades ago, to it's absolutely, I like the soundbite, kills. Where will we be with other nicotine delivery devices 10, 20 years from now? A researchable question for the young people here in the room. So thank you all for coming. Thank our panel, please, and Dr. Carmona.
Students,